Welcome, and thank you everyone for joining the Heart and Stroke Foundation's 2025 Stroke Month webinar, Vascular Cognitive Impairment, Advancing Evidence-Based Care Across the Continuum. My name is Rebecca Lund. I'm the Manager Stroke at Heart and Stroke, and I am so thrilled to be moderating today's webinar. Next slide, please. Before we get going, some quick information for you regarding how to enjoy the webinar today. When you join today's webinar, you will be joined through computer audio. If you prefer to listen with your phone, select phone call or call me and follow the prompts. Questions are welcomed during today's webinar. Please feel free to enter them through the question panel and they will be addressed as best we can during our Q&A period at the end of the webinar. Lastly, the webinar will be recorded and available on Heart and Stroke's YouTube channel, as well as the Stroke Best Practices website. As we begin today's webinar, we'd like to start by acknowledging the Indigenous peoples of all the lands that we're on today. While we meet today on a virtual platform, I'd like to take a moment to acknowledge the importance of the land which we each call home. From coast to coast to coast, we acknowledge the ancestral and unceded territories of all Inuit, Métis, and First Nations people that call these lands home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. We're gathered today because of a shared commitment to equity, including health equity and reconciliation. I encourage you to reflect on what that means for you and your work and in your lives. We have 3 objectives for today's webinar that you can see on the slide here. The first is to review and describe vascular cognitive impairment, or VCI, and its current state of evidence. We're going to discuss highlights from the new 7th edition Canadian Stroke Best Practice Recommendation VCI guideline, and also to reflect on the personal experiences of individuals living with cognitive changes following stroke. And at this point, I'd like to now invite all presenters to turn on their cameras. We have 3 incredible presenters today that I'd like to introduce you to. We have Dr. Rick Swartz, who is a clinician scientist and a stroke neurologist at Sunnybrook Health Sciences Centre at the University of Toronto. His research focuses on improving emergency stroke treatments and identifying and limiting vascular cognitive impairment. Clinically, he focuses on groups for which VCI is particularly impactful: stroke in young adults, complex causes of stroke, including pregnancy and central nervous system vasculitis. We also have Shannon Balick, a person with lived experience of stroke and advocate. She has been volunteering with Heart and Stroke since early 2022. After surviving a stroke in July of 2020 at age of 46, she spent weeks in hospital and rehab during the height of COVID, mostly alone. With a fighting spirit and a motivation that many around her were not surprised of, she dedicated her days to returning to pre-stroke life as best she could. As a wife, a mom, a daughter, a niece, a friend, an employee, and a person who's generally on the go all the time, Shannon worked hard to show stroke it wasn't going to win. Now, Shannon uses her experience to raise awareness that strokes can happen to anyone. She participates in stroke survivor communities, meets with survivors, and advocates for more support for young stroke survivors in Manitoba. Her goal is to change the face of stroke. And our third presenter, Dr. Stuart Longman, is a rehabilitation psychologist and neuropsychologist who was educated in BC and Ontario and has since practiced in Saskatchewan and Alberta. He has been a clinician with the Calgary Stroke Program since 1995, working with both inpatients and outpatients, as well as an adjunct associate professor at the University of Calgary. His research interests include cognitive effects of TIA or mild stroke and healthy cognitive aging. Please see the presenter disclosures on this slide. And with that, I'll now pass it to your first presenter, Dr. Rick Swartz.
Thanks very much, Rebecca. And it's an honor and privilege to be here today. This is a great turnout and to be here with our co-presenters, really to present the work that we've done on the Vascular Cognitive Impairment Canadian Stroke Best Practice Guidelines. These were developed under the leadership of Heart and Stroke Foundation Canada. They will and may discuss some off-label medication use. The guidelines are publicly available with a link here, as well as available on Heart and Stroke's Best Practices website. Also, you see the link there. And the other key context or warning is that 30 to 45 minutes doesn't give us a lot of time to delve deep into the guidelines. So we're going to be sort of hitting some highlights and giving context about the guidelines, but encourage people who are interested to go to the guidelines themselves for more details. Next slide, please. We're presenting on behalf of a a really wonderful expert group of clinicians, a multidisciplinary team, including everyone you see here, ranging from physicians to occupational therapists, psychologists, and really a very diverse team, as well as a community consultation and review panel, CCRP, of whom you'll hear more in a moment. Next slide. So we're going to talk about a little bit about VCI, the epidemiology of it, how common is it, what it is, with definitions of terms, and really emphasizing that it is more than just post-stroke cognitive impairment. We'll talk about that in great detail. We're going to look at a patient journey map and hear from Shannon, as you heard, a person with lived experience. And then we will review some of the highlights from the best practice recommendations. Next. Next slide, please. We are not. Why VCI matters. 1 in 3 Canadians will experience stroke, dementia, or both in their lifetimes. But cognitive impairment is even more common than dementia. Dementia is sort of the most severe end of the spectrum. Twice as many Canadians will experience some form of cognitive impairment than will experience dementia. Especially after stroke or TIA, cognitive impairment is very common. It affects from 1 in 5 to 4 in 5, depending on the samples that are studied. It depends a little bit on whether we're defining mild cognitive impairment versus more severe or dementia, whether we're looking at a group of people with their first stroke or with multiple strokes, whether we're looking at people in hospital or people who have survived their stroke and are now returning to outpatient clinics, and how hard we look, how we assess people for cognitive impairment. The other issue is that covert strokes, these are sneaky little strokes that don't tend to cause overt or symptomatic changes, so weakness or speech problems or vision problems, but we see them on imaging. And covert stroke is even more common than the symptomatic strokes or TIAs. They can accumulate without being noticed, and they can unmask or cause cognitive impairment. And we know that mixed disease, where we have vascular and neurodegenerative disease, is the most common cause of cognitive impairment. We also in the guidelines try to take a broader perspective. Again, we'll talk more about that in a moment, but cardiovascular surgeries can cause small strokes, covert or overt. Other vascular conditions like heart failure, congenital heart disease, atrial fibrillation are also associated with vascular cognitive impairment, as well as common risk factors like age, hypertension, diabetes, atrial fibrillation, chronic kidney disease, or obstructive sleep apnea. Next slide. So what does vascular cognitive impairment really mean? In the red box, we have some of the psychological constructs that are most commonly affected by vascular cognitive impairment, including learning and memory, executive function, that's like organizing, keeping track, shifting tasks, complex attention, keeping track when there's multiple things going on, perceptual motor function, coordination, language, social cognition. These are areas that are frequently affected by VCI. And then those effects have further effects. So they can make it harder to do self-care. Someone who lives alone may have more trouble keeping track of their medications, for example. Or there could be increased risk of adverse events from polypharmacy. People after stroke sometimes need a lot of medications. They have other conditions. Sometimes those conditions can worsen cognitive impairment, or cognitive impairment can make them more vulnerable to those side effects. And there can be a decline in functionality and independence, all of which can add up to quality of life changes or even reduce life expectancy, although that is not always the case. Next slide. So let's define our terms for a minute. It's important to understand that VCI is an overarching term. It represents a range of clinical presentations, a range of severities, and a range of progressions. There's multiple terms in the literature. Those of you who read the literature, I apologize. That's an alarm going off in my room. Hopefully that's not terribly distracting.
Blue 5 South, room 5. Code blue 5 South, room 5.
Sorry, one of the challenges of presenting in a hospital. We were discussing that multiple terms in the literature apply to vascular cognitive impairment. So in the literature, you will see terms like vascular cognitive disorders. The DSM-5 highlights vascular mild neurocognitive disorder and vascular major neurocognitive disorder. Don't ask me why they have mild and major as two opposites. They're not in the English language, but there it is. VCIND, vascular cognitive impairment, no dementia. Vascular MCI, vascular mild cognitive impairment, and that can be single domain or multi-domain. Even vascular dementia at the most severe end of the spectrum. All of these terms are in the literature, and they're kind of all encompassed by the more generic term VCI. Next slide. VCI can be defined scientifically or publicly. I'm going to focus on the high-level public description that VCI is a condition of the brain and its blood vessels that causes challenges with cognitive abilities like attention, memory, language, processing speed, judgment, and problem solving. Excuse me. We have a more detailed public-facing definition I'm not going to go into in excruciating detail, but it is here on the slide for those that want to or want to watch back in the recording. The most serious form, as I mentioned, is called vascular dementia, which causes problem in everyday activities like dressing and bathing and self-care. Vascular dementia and Alzheimer's disease can share some signs and symptoms. They can exist separately or together, but they're not the same condition. Next slide. The scientific definition of VCI refers to a range of new or worsening cognitive deficits caused by or accelerated by cerebrovascular injury, so the brain and its blood vessels. The cognitive deficits, and it's important here, have a definition that they should be new or worsening. We all have cognitive strengths and weaknesses that we've had since childhood. If it's the same that we've had from before, that's not really a new issue. But a new problem or a worsening challenge that affects any or all cognitive domains, single or multiple domains. And this also includes changes from focal stroke symptoms like aphasia, neglect. These are specific syndromes that the stroke can cause. And cerebrovascular injury means strokes, symptomatic or covert. They can happen cortically or subcortically. They can be strategic infarcts affecting things like the thalamus or the hippocampus, causing memory issues, or they can be more diffuse. And they can have multiple different causes, all the different things that can cause stroke. Well, stroke is cerebrovascular injury. And importantly, they can occur in isolation, or they can unmask or even accelerate underlying latent neurodegenerative disease that might have otherwise not caused problems for 10 or 20 years, but all of a sudden gets unmasked. And that's an important issue that happens when Alzheimer's disease, for example, co-occurs with stroke or vascular cognitive impairment. Next slide. We examined, we call it a heat map, but looked at what the published literature showed about associations between different conditions and vascular cognitive impairment. And you see that it's not just stroke. Congenital heart disease, coronary artery and vascular disease, heart failure are almost as strongly associated with cognitive impairment as strokes are. So it's not just the stroke syndrome itself that's associated with the cognitive impairment. Even atrial fibrillation, valvular heart disease, cardiac arrest, MIs have been reported to be associated with cognitive impairment. Next slide. So the framework in our, both in our journey map and in our guidelines, we really wanted to broaden out the conceptualization of VCI. It's not just post-stroke cognitive impairment. You see that kind of in the middle, where you have people presenting with stroke and then being assessed for vascular cognitive impairment, being assessed for cognitive problems. On the left side, you see many people present to memory clinics or their family doctors or geriatricians' offices with cognitive issues, cognitive complaints. Our guidelines are really encouraging that we should be assessing for neurovascular, for cerebrovascular injury. That means imaging. And people with multiple vascular risk factors, people that we just talked about, the hypertension, diabetes, smoking, or atrial fibrillation, heart failure, people undergoing heart surgeries, should be screened for both potential cognitive impairment and imaging findings to think about, do they have VCI? And so our guidelines cover all of these areas: neurovascular imaging, screening and assessments, diagnosis, treatment, non-pharmacological and pharmacological therapies, rehabilitation. Next slide. More than just this, we wanted to really go through, bed the guidelines in what individuals with lived experience face. And so we pulled together this community consultation and review panel, the students, family members, as well as to management and develop an educational resource. Next slide. So the journey map itself is driven by people's own experience. You don't notice things on the outside, but it's on the inside that you suffer with it. These are direct quotes from people in the CCRP. I am my own best expert on what I need. The harshest dose of reality was when I went home. I feel like I'm faking it. Um, I just feel broken and I can't do what I think I should be able to do. One of the challenges and one of the consistent themes I hear as a clinician, and that came out loud and clear in the lived experience discussion, is that VCI is often an invisible deficit. People see when somebody has weakness on one side, when they're using a cane, when they're using a walker. They don't see the vascular cognitive impairment. Even the people themselves that are affected sometimes struggle with sort of forgiving themselves that this is a real deficit, just like weakness of the hand might be. And even though you can't see it, it can be very impactful and it has to be dealt with and managed in order to compensate and recover. Next slide. I like screw you stroke. I'm going to do this just as an aside. That's my favorite quote. Next slide. So on the journey map, we laid out across different themes: symptoms, navigating care, managing daily activities, emotions and mental health, relationship to self and others, and tried to map that out from symptom onset all the way to long-term living. And what struck me, I put this little red box here, what really struck me is these 3 points are what we really do as physicians most of the time. We focus on maybe getting access to diagnostic imaging, confirmation of diagnosis, need for follow-up management plan goals and next steps. But that's one small little box. And there's all of these other issues in the VCI journey map here that have been brought up that are so much bigger than those 3 things. And so the guidelines were really intended and driven by this journey map to try to give some guidance to clinicians, patients, family members on how we can address the broader journey. Next slide. At this point, we're privileged to hear from somebody with lived experience, and Shannon Bayluck is going to share her experience with us in light of what we've heard about the journey map to really give us a sense of her view on this. So Shannon, thank you for being here. Oh, you're on mute. There we go.
Thanks. Thank you, Rick. Welcome, everyone. As mentioned, I had my first stroke at 46. It was an ischemic stroke. At first, I did not believe it was a stroke. It was a fleeting moment that it entered my mind, and then I dismissed it. I'm too young for that, and I just must have slept wrong. It was, in fact, though, a stroke. I had to learn to rewalk, talk, write, and being left side affected and being left-handed, just let that sink in. Left-handed, left side affected was definitely a fun time. Add in those cognitive challenges, and some days were very discouraging. But here is where being stubborn and hard on oneself can be a very, very good thing. One of the things that they found was that I had a PFO, patent Foramen Valley. So for those of you that don't know what that is, that's the hole in your heart, which allows blood to flow the wrong way to your brain. And this is where I throw in my reference to Hailey Bieber, and then everyone usually goes, oh, okay. So the hole in the heart photo is on the left side of the slide there. And it's a hand-drawn diagram that I was given in the hospital days after having that stroke. And I still marvel at the simplicity of this drawing, but at that time it made sense, and I needed simple because my brain wasn't working. I was scared. I wasn't sure what was going to be next. As I said, I wasn't able to walk. I wasn't able to do the simplest of tasks that only days before I could do. Words weren't coming as easy as they used to. Here I was in the hospital. I wasn't able to go home. As mentioned, it was the height of COVID. I was alone a lot of the time. Only my husband could come. We didn't know really what was going on. They were running a battery of tests. The PFO discovery was many days later. They were doing autoimmune tests. We really had no idea. I'm adopted, so we had no history to go off of. At this point, simple was the most important thing. And it helps. The experience itself and trying to keep my strength inside and outside was extremely difficult. The cognition part of this, what Rick was talking about, the changes that I was experiencing inside were very hard to share. The external things were obvious. I didn't present normal to start with. I didn't have the droopy face. I didn't have difficulty speaking. In fact, at first, even trying to diagnose the stroke was difficult. It was my own inner self that caused or me to call and have it diagnosed by paramedics, because our first diagnosis, myself and the people that I called down the street, we didn't see it. So it was the paramedics that diagnosed it. And by the time I got to hospital, it was too late for any of the things to be done medically. So CT diagnosed that I had had multiple strokes previously. And the cognition part is what we're here to talk about. So that's where I'm going to focus. And diagnosis of that, as Rick mentioned, is often very difficult. The tests I find are very somewhat not always so cut and dry. I believe that there's a gray area. And the people around the survivor really do know the person best. So yes, I was functioning at an extremely high level prior to my strokes. And I find that testing me was still turning out a pretty good result, but it was nowhere near where I was pre-stroke. So I found that really frustrating. And some days, and to this day, when I'm tired and I can't find a word and I get mad at myself for fumbling, nobody really understands. So this quote, when I went home, it was the harshest dose of reality. And some of those quotes that were shown those are worries and thoughts that are commonly heard. And these unseen challenges, those are true. This is why I'm on medical retirement. I was unable to return to my dream job. I can still do a lot of things, but I can't do them at the level that I was able to do before. Again, these unseen impairments where I pretend a lot. I pretend a lot mentally too. And you don't notice the things on the outside, but the things that you suffer with internally. The things that I live in fear of every day, I still do. It's less because of all the medications that I'm on. But the strokes, the TIAs, the seizures, they haven't happened in over 18 months. But imagine being my family member, and every time that I call, or I call randomly, I call more than once in a row. I'm not the only one that lives in fear. My family does. They still do every day, every time that I feel unwell, or I have a doctor's appointment that I have to attend to. I still do pretend. I exert a lot of energy just to be here today. I had to make sure that I had a good rest. I made sure that I had all of my notes ready and prepared accordingly. Next slide, please. So 2 years after having my strokes and having 2 strokes and TIAs and the other fun stuff that I hadn't been prepared for, because they don't send you home and say, by the way, here you go, be prepared for these things. I had the hole in my heart repaired. I've had to go for another review of my heart, as there's suspicion I could have another hole based on some of the symptoms that I continue to show. And again, no one prepared me for that. But at least now I know what to expect if that's needed again. I'm a half glass full type of a gal. I wish it was wine, but that's another thing. And they didn't advise me of that until afterwards. No more liquid spirits. The only spirits I have now are my own. You'll see here on the slide that I have my mobility pass. I don't call it a disability pass. I call it a mobility pass because I am still mobile. And some days I use it and some days I don't. It depends, as I said, how I expend my energy. Some days I expend it differently. And so you know that in the 5 years, there's only been one time that someone made me feel I had to explain why I've parked in a stall. And I challenged them, only because I felt I had to. The reason that I do a lot of my volunteer work is to remind people that not all the disabilities are visual. I have a cane. It's pink and it's fancy. I like to use it as an accessory, as it were. I don't always have to use it, but I use it when I need to. And some days I really do need to. I want to talk a little bit about the availability of appointments with specialists and the role of our primary care doctors and the importance of those. One of the quotes that you saw was being an expert on what you need. And it's so true, being your own best expert. Completing forms and having them done correctly and on time is very important. Making sure that those forms are done can be the yes or no on coverage. Making sure the wording is done correctly. Using descriptors and the narratives, they can be a yes or no on having those coverages done. It's important that our physicians and primary care doctors know the impact of their words on those forms. Having access and resources within city versus rural, that's also a very important thing. And as a patient, I want to make sure that those are also focused on. Cognitive changes and worries that can follow. Those are things that we also have to make sure are focused on. The secondary things, the things that I worry about as a patient, I know now what to focus on when it's going to happen. As I mentioned, the worries are daily for everyone. Next month will be my 5-year stroke anniversary. Those are what we in the stroke survivor world call them, stroke anniversaries. I have a moment on that day, and I think about that time when my life changed. Someone asked me once if I would take it away and not have had the stroke. I say no, because it's made me who I am now. I advocate and I speak for those who can't, and it's important for me to share that. I want to remind everybody that strokes can happen to anyone at any age, and it has a variety of impacts to each survivor, as no two strokes are the same. I want to remind everybody that recovery never ends, and every day is a new day and something that can improve every day, even if it's something small, and that you should never give up and never let anyone tell you you can't do something. As I've already said, and it's very important to me, stroke is not an age thing, and I want to change that. In this slide, you'll see a logo. That logo is actually my face. It's my side profile. And along the ribbon, you'll see changing the face of stroke. And that, again, is my goal. It's a logo that I've trademarked because it's important that this goes. Thank you for your time, and I hope that you enjoy the rest of the presentation.
Thank you so much, Shannon, for sharing with us your experiences, your perspectives, your insights. We are so grateful. Thank you.
Thank you.
I will now pass the mic to Dr. Stuart Longman.
Thank you. And thank you, Shannon, because this is why we do this. We should not just focus on diagnoses, techniques. We need to focus on people. So for us to help you most effectively, to help others with similar experiences, to help your families, we benefit from practice, we benefit from guidelines, so we don't have to come up with a new, entirely from scratch plan every single time. So as you can see from this slide, there are many different parts for us to look at, from identifying what's going on, choosing the proper tools, choosing what to do, beyond the techniques, looking at the people, individuals, family, caregivers, appropriate supports, because so much doesn't happen in the healthcare system. And for those who have been living this with this for a great deal, or who have end of life concerns, how do we approach that in the most effective way? Okay. Now we'll start to get into more of this. And next slide, please. So I have to say that developing the guidelines was a good deal of hard work, and I'm also very grateful that Heart and Stroke team did most of that hard work even before the advisory committee got involved, reviewing the literature, what had been demonstrated to be helpful, and more important, what had not been helpful, coming up with an organizational strategy. So that foundational work was crucial. And in the end, we came up with 87 recommendations. That is 87 things that have clear documentation to say this is helpful. We also came up with 53 clinical considerations where these are things that may be helpful in specific circumstances. These are things we need to think about when we're providing our services, or these are things that seem reasonable, but the evidence isn't there yet. Um, we know that these recommendations will change over time. In fact, Heart and Stroke has said we are prepared to do a 5-year review of these recommendations to add things that are demonstrated to be helpful, remove things when there's evidence they haven't been helpful, speak to new technologies. So this is a living document, and it will continue to evolve, and I trust our colleagues at Heart and Stroke will be very busy with this. Next slide, please. Now, I live largely in the assessment world, so screening is very important. Some of the issues are that for folks who have had a stroke or a TIA, for folks who show signs of stroke or stroke-related changes on brain imaging, we need to think more and more about how are we going to check for changes in cognitive functioning. So there are many ways to do this. Asking patients and their caregivers, looking for evidence of difficulties such as missing appointments, um, doing in-office brief screens. And in fact, there's also some online self-administered tests that may be done uh, where Cognicity or Creos may be very helpful when we're looking at the wide variety of issues. We know that we need to have some brief tools that can tell us we should be concerned, or brief tools that say we can be less concerned now. Okay. Thank you. Next slide, please. So here are some examples of some cognitive screens which can be useful in different settings, such as clinics or doctor's offices. Some of these are very brief, such as the mini-cog or the doc screen. Others are longer, such as the MMSE or the MoCA. Many of these require specialized training, such as the MoCA. In my world, uh, based largely in hospital practice and with a number of people who clearly have had strokes, tools such as the Oxford Cognitive Screen or the ACE-3 have been very useful. And the ahs.ca website has been a useful resource for learning more about these tools, which will be covered at the end. General strategies include looking at memory, visual spatial skills. We love to ask people to draw clocks. Okay, and Dr. Swartz can speak more to the doc screen as a tool that he co-developed. Okay, next slide, please. Okay, we do know that screens can be lengthy, screens can be short. A short screen, even a single question, is better than nothing. And long screens can be time consuming, can require training. So asking your patient, have you noticed problems with thinking or memory? Have you noticed concerns about your family member? Informant interviews for family members are very useful, highly sensitive, so they are good at detecting issues. And if they don't identify issues, that's also important. We want to avoid, lengthy assessment of people who don't need to be seen. That sucks up a lot of time. But we also want to make sure that we see those people who do need to be seen. Next slide, please. So we do know For example, when you see your family doctor, you almost always get your blood pressure checked. When you see your family doctor, you should almost always get your cognition checked. Um, Early evaluation can be important, flagging services that are needed, identifying potential risks, making plans for what happens later. We also know that catching problems early can lead to much better outcomes for folks who are at risk of further strokes, for folks who have blood clotting disorders. Catching consequences early can lead to treatment and prevention of further decline. Uh, we know that one of the nasty parts of cognitive impairment is that it can affect our ability to notice difficulties. So family and caregiver reports can be very important. Finally, we know that because there are so many tools, that it benefits clinicians to be aware of several different tools that can be useful for different contexts. For example, the RUDAS is a very useful tool for folks from different backgrounds and cultures with a focus on everyday difficulties and challenges rather than academic-based questions. So next slide, please. So, and we know that screening and assessment is always important when there are documented issues, when we know we need to look further, we need appropriate professionals. For example, neuropsychologists, occupational therapists, speech language pathologists, um, and assessment needs to look at a wide variety of areas, including language, reasoning, memory, attention. We need to look at executive function and thinking speed. We need to consider the effects on mood and coping, especially the effects on everyday life, because we're not interested in the brain in a jar. We're interested in your brain, in your head, in your life. Um, and a proper assessment should always look at medical issues that can be affecting functioning. Okay.
Stuart, just giving you a time update.
Okay, thank you. Um, the problem of speaking about things that we're so passionate about is it's hard to be brief. Fortunately, I've actually just covered all of this, so we can move on. Okay, but we know that people's own lives and situations affect what will happen. We know that seeing people early in hospital when they may be very confused and overwhelmed may overstate difficulties. We know that people with hearing impairments and vision impairments will be affected on our testing. Um, I'm going to skip the next slide, and I'm going to pass the baton to Dr. Schwartz. Thank you.
Thank you, Stuart. And I'll slide it back to you in a moment. As we talked about, we want to screen and assess cognitive impairment for people presenting with stroke. We want to also, if people have cognitive issues, we want to think about imaging. And also, if they present with a stroke, we want to think about imaging. So MRI is our preferred method over CT for investigating VCI if there's no reasons that an MRI couldn't be done. And we gave some suggestions for the type of CTs if a CT is done. And as Stuart was alluding to, there's a lot of clinical considerations for physicians about why. So MRI is more sensitive than CT for vascular changes. And it can also provide more accurate information about other contributors. There's specific STRIVE criteria for radiologists to support the reporting. And then we also don't want to forget about laboratory investigations for stroke risk factors and contributors to cognitive impairment like thyroid or B12, calcium. Next slide. For non-pharmacological treatment, there's a lot that can be done to support people with VCI. In fact, a grad student of mine recently, well, several years ago, published a paper in Stroke where a brief 10-second intervention prompting people to really develop focused, motivational, aspirational goals on their cognitive testing. Okay, last time I did this cognitive test, I remembered 10 words. I'm going to try to remember 12 this time. Just that actually improves their measurements on tests. And this kind of thing can work in the real world too. So people with VCI should be assessed for medical and lifestyle risk factors and supports, communication tools, memory aids, compensatory strategies, external, so family and caregiver community support that can optimize their participation in goal setting, optimize their engagement in interventions, and optimize their quality of life and participation. And even things like, as Shannon was speaking about, exercise, sort of energy conservation. So being strategic about where you spend your energy will actually help preserve focus and attention. Many people find at the end of the day, or when they use up all their spoons, as people say, it gets harder to focus. We have sections additionally on management of mood, behavioral risk factors, safety and risk management, and environmental supports that have a lot of detailed recommendations. We don't have time to cover all those today. Next slide. For pharmacological management, there is some weak evidence that drugs used and proven in Alzheimer's disease, cholinesterase inhibitors like donepezil, also known as Aricept, rivastigmine or Exelon, and galantamine, as well as memantine, could be considered in people with vascular or mixed dementia. But these are based on small trials that show small magnitudes of benefit. So these are not revolutionary treatments, and they do have side effects. So we have a conditional recommendation. There's high quality, consistent, actually, I apologize, the trials weren't small, but the benefits were small. So we have high quality evidence suggesting some benefit. So it is worth considering a trial for people, but it is by no means a strong recommendation, and we have to nuance that with being careful about risk factors. And we should also think about deprescribing. So certain classes of medications can worsen cognitive function on their own. Fortunately, most of the stroke prevention medications don't do this, but there are many other medications like sedatives, some mood medications, some prostate medications, some urinary medications that can actually worsen cognition and should be reconsidered. Next slide. I'll hand it back to Stuart.
Thank you. So the point of much of this, we identify cognitive concerns, we identify and treat medical issues. Let's treat the cognitive concerns as well. So assessment should say, here's what will be helpful. Otherwise, it's just labeling. Working with the individuals, working with their families or caregivers, can be really important to develop a plan that's relevant for them. Doing something that feels like hard work in the lab or in my office that is irrelevant to your life may keep me busy, but it's not going to be useful for our patients. So what are the goals in your life? Again, Shannon spoke to that. We know that practicing specific skills of attention, memory strategies, particularly skills with planning, organizing, managing energy are important. Using more global strategies, so things that affect everything. So physical activity is the perfect example of the global strategy. We know it affects endurance. We know it aids cognitive functioning. We know it aids thinking speed. We know it aids cardiovascular functioning. So this is something that is really important. Finding an activity that you care about, that engages you, and that has a positive effect on functioning is really crucial. And we know that this can differ depending where you are. Okay, next slide, please. So practicing skills. So the attention and memory exercises, for example, think about tools such as Brain Age or Big Brain Academy, practicing compensatory strategies. I'm here with my day timer in front of me. It's always here. That's a compensatory strategy that I've used for 20 plus years, and I'm probably going to use it for many more. Home automation, Siri, Alexa, these can be very useful. And I meet more and more people who are using these. We know that early intervention can be very important. We know that reviewing people's progress and reviewing their needs is really crucial. Finally, something that we often overlook, social supports can be very important. Social supports may be family. Social supports may be social activities and groups. It turns out doing social activities is very important for developing cognitive skills, focus, and attention. Um, Next slide, please. We know that education is crucial. Fear holds people back. Apprehension holds people back. Education can be really important for how is this useful for you, for now, for your life. Uh, we know that families have their own needs. We know that supports for families can be important, including supports to how they can help manage conditions. For example, problem-solving approaches with their family member, mindfulness-based stress reduction, a psychological technique that I'm very fond of, that can be very useful when people find that they're getting overwhelmed, agitated, frightened, or frustrated. Again, thank you, and I'll pass the microphone to Dr. Swartz.
Oh, thanks, Stuart. Caring for the caregiver is vital. And as disease advances or progresses, or when there's severe impairments, we also recommend that people consider advanced care planning. We are advocating, this again came out in the journey map, about thinking about long-term wishes while things are still good. And that's something I think everybody should do across the lifespan. But especially if things are progressing, not all VCI does progress, but some does, especially when there's overlap, as we mentioned, with dementia, or if we're in the severe end of the spectrum. Empathetic advanced care planning should be integrated as part of a comprehensive care plan, and should be documented and reassessed, because some things that are relevant now may be very different 2 years or 5 years down the road. Next slide. Sorry, next slide. There we go. Especially when there's advanced disease, optimizing quality of life and care should really be the focus. Whether palliation is actually wanted or not, quality of life is still an important focus. And we have a list of topics to consider discussion, like mechanical ventilation, putting a breathing tube in, putting feeding tubes in. These are things that should be ideally discussed before any emergency situation, so everybody sort of has an understanding of what wishes would be. Next slide. So we hope that you can see from our presentation today that we've really tried to address and embed the guidelines in the feedback and journey map that was developed by persons with lived experience, and in stories like we heard today from Shannon about the invisible deficits and the importance of communication, education, and management. Cognitive impairment is common with vascular disease. Cerebrovascular disease is common in people with cognitive impairment. VCI should be thought about in people, whether they present as a stroke pathway, a cognitive impairment pathway, or in vascular clinic settings. And the journey map really highlights some of the unmet needs that we hope the guideline will start to address. VCI impacts people throughout the spectrum of age, throughout different stages of life, but also severities of impairment, including end of life and palliative care. And early screening, imaging, assessment, treatment, rehab can all positively impact people's quality of life, as well as their own day-to-day activities and their families' lives. We hope the guidelines will help direct pragmatic first steps for physicians, caregivers, patients, persons with lived experience, as well as provide details for specialists. And probably the biggest goal of the entire guidelines and talks like this is to open the door to the conversation. We want to make it thinkable. We want to make it understood that there are things that can be done to help, and we want people to avoid therapeutic nihilism. We don't want people to say, there's nothing I can do anyway, why bother? Because there's lots of things that you could do. Next slide. We are going to ask all the panelists to come back, turn our screens back on, and we're going to open the discussion to questions. And thank you, everybody, for your attention.
Thank you. And lots of incredible questions coming in through the chat. So apologies if we don't get to all of them. The first one that we have is for you, Shannon. If there is one thing that you hope healthcare providers listening could remember and bring into their practice or bring into their work, what would that be?
Taking the time for people with cognitive challenges. We need that extra time. So I found it very difficult to take in information and then regurgitate that if I didn't have someone with me. And especially during COVID, because I was attending appointments alone. And because I couldn't use my left hand to take notes, it was extremely challenging. So not only could I not record them properly, I was using my right hand, trying to do it on my iPad. Then my brain wasn't working. So when I got home, I couldn't really read my notes, and then I couldn't remember what they were. And there was no notes for me to give to my family. And because I couldn't take anyone with me, I couldn't accurately give the information. So taking time and allowing people to come, and then maybe having a note that I could give to somebody, or maybe they could phone in, or just having somebody to have the information for me. That would be very important.
Wonderful. Thank you. And Rick or Stuart, anything that you would like to comment on as well? Otherwise, I'll go to the next question.
Strongly encourage what Shannon, seconding what Shannon has said. We like to have family or supporters there. It doesn't have to be family members, but having somebody else there in person, by phone, on Zoom. Fortunately, I think health technology has evolved a lot since the early days of COVID when Shannon was unfortunately sort of in the midst of this. And I think hopefully a lot of clinicians are more open to getting someone to Zoom in or call in to be a part of discussions if they can't be there in person. I think that's vital.
And ask for written notes. That's often quite easy to do and extremely helpful. Never be shy.
Wonderful. Thank you. This question, I think, for any of you to weigh in, it's about being in a busy clinic where there often isn't time for a full neuropsychological battery or even quick screens. Is there one thing that you would prioritize with limited time? And what would be the next step if the results required some follow-up?
So that's a great question and one we get asked a lot. This is where Stuart was emphasizing, medical history taking, we ask questions all the time. So just ask the question. Are you having problems with your thinking and memory? Or to a family member, have you noticed changes in their thinking and memory since the stroke? If the answer is yes, then have a plan for an occupational therapy referral, neuropsychology referral. Private psychology assessments are usually quite expensive, but in many places around the country, there is either OT or psychology assessment services affiliated with the stroke system that people can get assessed through the system rather than having to go private. So that's for clinicians, I'd encourage, if you're only going to do one thing, at least ask the question and have a plan, have someone you can refer to that is covered provincially for more detailed assessment if a flag is raised. Yes, I have concerns.
And fortunately, there are a few online self-administered tools that you can use now. Some of those are mentioned in the heart and stroke guidelines, and I would heartily support that as an excellent first step.
Highly support, not hardly support.
Both. Heartily.
Thank you so much. We're getting some questions about kind of returning back to the question that was asked of Shannon. From a healthcare provider perspective in the clinic, is there technology that can help people with the note taking, or is there anything that they can utilize to support if they aren't able to have somebody in there with them or readily on the phone?
Yeah, so I think that's coming. We're in an era of numerous AI apps for medical, specifically for medical, not ChatGPT listening in on our conversations or something like that, but medical apps with privacy and security features built in. I've been trying to use some of those at Sunnybrook and have had to pause as the institution is now trying to develop policies and use agreements and things like that. So these things are not quite out there routinely yet, but I would say within the next 1 to 2 years, these are going to be all over the place, and they can generate fairly good, patient-facing summaries as well as helping physicians, with dictated letters. So I think that's going to see a sea change in what people can get out of their doctor's appointments. So I think that's coming. In the meantime, that becomes a individual and physician decision. I personally have no problems when patients ask me if they can record our session, but some physicians are uncomfortable with that, or clinicians are uncomfortable with that. But I do think things like the AI approaches are going to be revolutionary when they start.
Great, thank you. Stuart or Shannon, any tips on that technology to support note-taking or retaining information on an appointment?
I'll just say for the Alberta experience, there is the My AHS app that allows for recording and access to notes, which has been very helpful for a number of the patients that we see.
I now just have somebody, usually my husband, come with me, and that's my secondary set of ears and my backup.
And I find most patients are able to at least get somebody on the phone. So even if your husband has his own doctor's appointment or something, it can't be in the same place, we can at least have them on the phone during the conversation. So that's usually my default backup.
Great, thank you. This question's a little bit broader. So thinking about the healthcare system, it can be challenging for people living with VCI at times to access the healthcare system, probably for a variety of different reasons. But do you see a role for technology in that, or strategies there?
Shannon, I don't know if you want to speak to your own, how you've used that. I can speak to that as well.
Sure, I can just say something briefly. I think it's amazing the technology that we're able to use just for quick calls or touching base with somebody. Testing, I think you guys could speak to, but just to do quick calls and check-ins, I think is good. I'll leave it to you guys to talk about the
I think it does depend a little bit where you are, and this is a moving target. So some clinics are moving to a lot of email-based communication with patients, which sometimes is easier than having phone calls and forgetting because it's actually in writing, to Shannon's earlier point. You have the appointments documented and available. Certainly using reminders and calendars and apps that help you keep track of appointments, help you keep track of medications. Like, I think there's a lot of things that can help people be their own advocates and stay on top of things. The medical system is slow on technology adaptation, right? Even with electronic medical record systems, we still use faxes. So to have my computer fax somebody else's computer, it's a little bit mind-boggling. So, I don't expect things like AI communications are going to, change things like that. Medical system is conservative and cautious and slow. So a lot of that ends up falling either to the clinics more largely. So things like the AHS app or MyChart, which is in a lot of Ontario hospitals, are helpful for people. And then I think figuring out the best way to interact with your clinicians, be that phone call to the secretary, emails, ocean technology, to communicate securely. Different clinics right now are all using different tools. So a lot of it is really going to have to be personalized, but finding a way to navigate with your key trusted providers is important. And the last thing I'll advocate for, I think both Stuart and Shannon mentioned this as well, is primary care has a key role here, to be the linchpin, and really connecting and establishing a good relationship with your primary care doctor. Having a primary care doctor in this day and age is a key thing for people with VCI.
Thank you so much. And thank you everybody for your thoughtful questions and of course the thoughtful answers. And Shannon, I just want to highlight that you're getting many thanks in the Q&A as well. So big thank you to you again. On this screen here, you'll see some resources from Heart and Stroke. We will also circulate these so that you'll have the links. But otherwise, on behalf of Heart and Stroke, we want to extend a heartfelt thank you to all of the presenters today and of course, everyone who tuned in. We really appreciate it and we hope you have a wonderful rest of your week. Thank you and take care, everyone.